To open the second half of the webinar this evening, I would first like to introduce myself. My name is Catherine Gebhardt, and I'm the head of Vitrolife Igenomix in Asia Pacific. Today, I have the pleasure of introducing our second speaker, Dr. Tristan Hardy. Dr. Tristan Hardy is the Medical Director of Genetics for the Monash IVF Group. He is the only dual qualified obstetrician and gynecologist and genetic pathologist in Australia, making him uniquely qualified to provide expert care in preconception, pre-implantation, and prenatal genetics. In addition to his clinical fellowships, Dr. Hardy completed a PhD in pre-implantation genetic testing, and he continues to develop new approaches to pre-implantation genetic testing, or PGT, and regularly collaborates with world leaders in the field. Today, Dr. Hardy leads the genetic laboratories and genetic counselling services across the Monash IVF Group, which includes where he's located day-to-day at Repromed in South Australia. And he's involved in all areas of the reproductive genetic testing that takes place in the Monash IVF Group. He is supportive of all couples undergoing genetic testing as part of their fertility journey, and he is passionate about providing the best possible care for all patients. Today, Dr. Hardy will be presenting a clinician's perspective on PGT-M, harnessing genomics in an IVF setting, and he will share his expertise and experience on pre-implantation genetic testing for monogenic disorders, or PGT-M, which has become a valued reproductive option for couples at risk of having a child with a single gene condition. So with that, I'd like to hand over to Dr. Hardy. Thank you so much.
Thanks, Catherine, and thanks, Vitrolife, for asking me to speak tonight. And I'd like to start by talking about pre-implantation genetic testing, both as such a valuable clinical tool for individuals and couples with a high chance of having a child or a pregnancy with a genetic condition. And it's also something that has given us so much in terms of our understanding of the biology of early human development. I think that the understanding that we have when we start to test embryos, we've understood that they have these unique predispositions to aneuploidy. And as Dr. Lee has already mentioned, that a combined approach looking at single genes and aneuploidy really is the best approach from a clinical perspective. So just to briefly cover the types of pre-implantation genetic testing and the updated terminology, pre-implantation genetic testing really refers to all types of tests that can be performed on an embryo biopsy sample, typically a trophectoderm biopsy these days, but also blastomere or polar body biopsy. It used to be distinguished as PGD and PGS, PGD being pre-implantation genetic diagnosis, where there was a specific question in mind that you wanted to ask in the genetics laboratory, and pre-implantation genetic screening, or PGS, where we were looking for the random aneuploidies that occur during the development of an individual egg or sperm in an attempt to improve IVF outcomes. In PGD now, we think of in terms of monogenic conditions of PGT-M, or structural rearrangements, PGT-SR, where again, the specific information from a family's genomic background is utilized to design a test specifically for them, and PGT-A, or pre-implantation genetic testing for aneuploidy, when we're looking for something that occurs as part of the development of any individual embryo, and the idea being to exclude the transfer of embryos which have a very low reproductive potential. So many people may not appreciate it, but PGT was actually the inspiration for IVF and not the other way around. And the team that won the Nobel Prize for the development of IVF technologies in the early 60s were already demonstrating that you could utilize IVF to access the genome of an embryo. And here we have a paper from 1968 where Bob Edwards and Gardner performing a biopsy of a rabbit blastocyst. A rabbit blastocyst is much larger than a human's, and so you can see some ophthalmic scissors coming down in the top right corner and a glass pipette taking some trophectoderm. And the aim of this was to sex the rabbits to determine the male and female offspring ratio before transfer to the uterus. And their thought was at this time, they were following on from their earlier publications, to say that the plentiful supply of oocytes from one ovary could allow some control over the reproductive options for couples who have a genetic condition. And so whilst they didn't have a good understanding, particularly of the molecular mechanisms which led to each disease, they did understand the patterns of inheritance. And so for X-linked recessive conditions, for example, had suggested that if you were to only transfer females, that would be a safe way of achieving pregnancy for individuals who are known to be a carrier of an X-linked recessive condition. But of course, Bob Edwards had interactions with the gynecologist, Patrick Steptoe, who developed the protocols for accessing eggs and laparoscopically initially, and really thought of it as a treatment for tubal infertility. And obviously, Louise Brown presented here, as born in 1978. And really, so much of the IVF world is clearly focused on the treatment of infertility. But I think that that's going to change as our understanding of genomics only increases. And so we have carrier screening, carrier genetic testing, which I concur with Dr. Lee, has about a 2 to 3% pickup rate when you're doing an expanded panel. There are people with rare conditions in their family, and of course the common autosomal dominant conditions that people access PGT-M for. And really, we might start thinking of IVF as half fertility and half genetics, because there may be as many people out there who wish to access it for genetic reasons as there are for that of fertility. So Professor Alan Handyside and Professor Robert Winston were the first to achieve pregnancies and live births following pre-implantation genetic testing of an embryo. And this work was done in the late 80s and early 90s in London. There were similar groups in the States at the time, and closely followed by Australia. And really, when they performed this testing at first, they had only one marker to look for, and that marker was some Y chromosome specific sequence that they have amplified here and shown on a gel where the arrow is. And the idea here is that they're aiming again to do what Bob Edwards had suggested, that if you just knew this one fact about an embryo, whether it would be male or female, you would be able to avoid some of the reproductive risk in the couples who initially had X-linked recessive conditions. It got a little bit more complicated a few years later, looking for the Delta F508 variant in the CFTR gene. And what's remarkable here is that not only have they developed a specific protocol for this variant, but it's only 3 years after the discovery of the gene itself and that variant as the major contributor to CF in the Caucasian population. And it's important when you read back through the papers that they presented here, and this one is in NEJM, there's a wonderful description of the genetic counselling aspects, which details the sort of information that the couples were given before this procedure, noting that it's the first time that this has been done for this reason. Recommending prenatal diagnosis to confirm the diagnosis, noting that pre-implantation genetic testing can never be 100% accurate. And really giving these couples an option for further reproduction, because they had actually elected, and most of them had tubal ligation. They weren't willing to take the chance of having another child or pregnancy affected by the condition. So here, Alan Handyside and Robert Winston there with one of the first families that had pre-implantation genetic testing when they brought their child back a few years later. So this really is a moon landing. It's a single event or a single sort of series of events and a program that was developed to do what is very, very difficult testing at the time from a molecular genetics point of view, and to achieve what is incredible achievement in terms of pushing the field forward. In terms of indications for PGT, though, since those early cases, it's grown into a huge field, and really there's anything that you can have a molecular diagnosis for, and even some things that you can't have a molecular diagnosis for are still available for PGT. So monogenic conditions, no matter how difficult that variant is, not everything needs to be able to be directly tested in an embryo, and we'll talk about why that is. So even very complex variants from a genetics diagnostics point of view can be tested using family linkage. You can perform HLA matching, so for the selection of siblings who would be suitable bone marrow transplant donors, umbilical stem cell cord donors for their siblings who may need bone marrow transplant. Exclusion PGT, where an individual may not wish to know their own genetic status with regards to dominant conditions such as Huntington's disease or motor neuron disease that's inherited in the family. You can give them the option of reducing the chance of passing that condition on if they are positive without needing to know their own status themselves. PGT-SR, or structural rearrangements, which impact on your ability to form an egg or a sperm with the typical amount of DNA. And even with it now, the identification of translocation carrier embryos being an important part of our program. There's PGT-A for the improvement of IVF outcomes and also for medical sex selection. So for conditions in which the genetic diagnosis is not confirmed, but it's known that males or females may have a differential risk of being affected by a condition. And most common indication in our group is probably autism spectrum disorder. So whilst it was very technically difficult and challenging to perform the initial PGT cases, we now have much more streamlined methods in the lab, and genome-wide haplotyping using a SNP array has really become the predominant method for performing a PGT-M case. And really the principle of it, and Dr. Lee has outlined already some of the processes of PGT-M, but to perform a trophectoderm biopsy, to look at unique individual molecular barcodes or SNPs that are in an amplified DNA sample, and to analyze that sample with respect to a family reference. So I describe to my patients that SNPs are really just little tiny spelling errors in our DNA. They actually have no consequence for the utilization of the instruction, but they are differences that can uniquely identify whether you've inherited that chromosome from your mother or your father. And a way to imagine it is if you look at two different books in English, but you're looking at American or British English, they will have different spellings of the words that are, of course, meaningless to the overall understanding of a sentence, but can identify which copy of the book that you might have. So imagine if you had one American and one British parent, you would be able to tell their DNA by how their S's and Z's were used in the words. So say we have a couple where the woman has a pink and a purple DNA fingerprint, the man has a green and a blue DNA fingerprint, and we know that one of her parents has been affected by an autosomal dominant condition, say breast cancer due to BRCA1 or BRCA2. We would look for the family member who was affected and assign that particular DNA fingerprint to the parent of origin. And when we look, say that it was her mother in this case, who had the pink DNA fingerprint, we would look for that DNA fingerprint around the gene of interest in the embryos, and we would assign them as high probability of developing the condition, as opposed to the embryos which had inherited her father's copy, which is the purple DNA fingerprint, which have a low probability of having the condition. So in reality, embryos don't inherit just one or another grandparent, of course, because of the process of meiosis, that information switches over in each chromosome. And what's unique about doing a genome-wide approach is that you can zoom into any area of interest, say in this case, the HBB gene. You could also zoom over to the HLA region and select not only a child who is unaffected by the genetic condition in the family, but was also a suitable bone marrow transplant. And so that's where you can do really as many genes as possible. And we have actually had multiple couples come through our carrier screening program who actually are at risk of multiple genetic conditions at the same time. So from moon landing, I would say that this genome-wide haplotyping is really the satellite technology era. Really, we've got to the point where if it doesn't work in the lab, we complain because we're so used to them working so clearly and providing us with all of the information that we need on tap. So what is the process from the patient point of view? Well, we would start with a fertility evaluation, a genetic test design, which we refer to as feasibility studies, working out whether the test will be possible or not. They undertake an IVF cycle with embryo biopsy and freezing, and genetic testing of embryos is followed by embryo transfer and pregnancy care. In terms of fertility evaluation, I would start with ovarian reserve testing, particularly the AMH as a predictor of the number of oocytes obtained. Because truly the AMH or ovarian reserve and the female age are the biggest determinants of success in terms of PGT-M. A semen analysis is performed to confirm that this sample will be suitable for ICSI, and routine infection screening, karyotype and blood count are performed in our unit. In terms of the genetic test design, we typically take a DNA sample from each of the egg and sperm provider and at least one relative. So typically it may be an affected child or pregnancy would be the ideal reference, but otherwise a family member who's known to have the specific genetic condition, or a family member who's confirmed not to have the genetic condition, because you can obviously select for the other person's DNA fingerprint. It takes us around 4 weeks to compare the DNA fingerprints and create a test for the embryos prior to starting an IVF cycle. And we do typically say that you can only proceed to IVF once the genetic test design is complete. However, in unique circumstances, sometimes someone will come in with a genetic diagnosis. And one time I was performing an egg pickup, and we diagnosed them with hemophilia A carrier status on the day based on their factor VIII level and their bleeding tendency. So you can obviously convert to a PGT-M cycle by simply biopsying the embryos, storing the DNA, and then later on doing the analysis using the appropriate samples. In very rare cases, we're unable to design a test, but in most cases, I would say 99.9% of the time, we're able to provide some option. IVF involves egg collection on day 0 and insemination, again, typically by ICSI, but if we require IVF for fertility purposes, we can perform that, noting that there is a risk of DNA contamination from the sperm. Embryos develop over day 5, 6, and 7 and are assessed for biopsy, and the trophectoderm biopsy is performed by an experienced embryologist. When we look at results, we do what I tell my patients is a zoomed in analysis of the gene of interest, as well as a zoomed out assessment of aneuploidy, because really concurrent detection of chromosome errors is really important when you're looking at a PGT-M cycle. You don't want to have to go through multiple transfers of embryos that really have very low reproductive potential. Most people are aware of the idea of PGTA using next generation sequencing to compare the amount of observed over expected reads in a sample, but they're less familiar with how it may work in the PGT-M setting when you're using DNA fingerprinting. So imagine that the egg provider and the sperm provider each have a unique DNA fingerprint. If her DNA fingerprint was purple, we would know that there was a blue and a red DNA fingerprint there. And if his was light yellow, we would know that there's a yellow and a white DNA fingerprint. Now, you would then be looking at an affected child as a reference, and you'd have to try and work out which particular DNA fingerprints were close to the gene in question. So if the DNA fingerprint was green, you'd be able to surmise that there was a blue and a yellow contribution from each of the parents there. So you would be looking for embryos that didn't have the same DNA fingerprint as the previous child, so avoiding the transfer of a green embryo. But in this case, all of the other DNA fingerprints would be suitable with regards to the gene of interest. But then if we were to zoom out and look at the other chromosomes and the options for transfer, we might expect to see a range of DNA fingerprints. And if each of the parents has contributed one chromosome, then we should expect to see those same combinations of colors again. So in this sample, it's euploid. All of these colors are available: light blue, pink, orange, green, all suitable combinations of those initial 4 parents' chromosomes. But imagine that there is an embryo here with a yellow fingerprint on chromosome 16. So we can surmise here that the father has passed on his yellow chromosome, but the mother has not passed on a chromosome, and that's a maternally derived monosomy 16. And equally, there may be an embryo with a purple DNA fingerprint that's over chromosome 21 here. And that indicates that there's 3 copies of the chromosome. So blue, red, and the white, making it light purple. So this sort of process is not necessarily chromosome wide. Of course, because of the meiotic recombinations, you do see these areas of what are called dual haplotypes, or both DNA fingerprints being present in just a part of the chromosome. But that specific tag is very, very sensitive for the detection, very specific for the detection of aneuploidy that's derived from the egg or the sperm. So what are the outcomes from PGT-M cycles? Well, the outcomes from PGT-M cycles are best looked at in really large data sets. And if you look at this publication in 2022 in fertility sterility, they looked at about 5 years of data from SART, the National US Database, and looked at patients undertaking PGT-M. What you can see is of those that proceed to egg collection, the majority, about 50%, would have 1 to 5 embryos tested. I always tell my patients it's about a handful of embryos that you can expect to be tested in this scenario. There's the possibility, a small possibility, that there are no embryos for biopsy. And there's also the possibility that you may do better than 5, but there's less people who do so. And it obviously depends very, very much so on the ovarian reserve. In terms of the cumulative live birth rate per cycle, it really just follows the maternal age, because the age of the egg provider is going to determine the chance of random aneuploidy. Of course, there is the random luck of the Mendelian process of a dominant condition affecting 1 in 2 embryos, or a recessive condition affecting 1 in 4. But what we see is that that coin flip is, I mean, there's nothing you can do about that coin flip, but you just hope that it occurs in embryos that are euploid and suitable for transfer. So the cumulative live birth rate per cycle really just reflects the declining outcomes in IVF cycles across those age groups. But when we look at the transfer of an embryo in any of those ages, they actually have equivalent pregnancy rates of about 45 to 55%. And that's because you've done concurrent PGT-A in your PGT-M case. So you've reversed or removed the age-related effect on aneuploidy. So in conclusion, genome-wide haplotyping really is the way to do it in the lab. It provides a streamlined workflow for patients and laboratories to achieve very high accuracy PGT-M results and perform concurrent PGT-A. And with that, I'd like to thank you again for inviting me to speak tonight. And if anyone has any questions, very happy to answer them now or via my email, which is on the screen.
Thank you so much, Dr. Hardy. That was a fantastic and very informative presentation on the way that PGT-M is incorporated into the patient care process. We'll now move into the Q&A session. So a reminder that you can use the Q&A box, which is at the bottom of your screen, to send in some questions. We do have some questions already, which is fantastic. And I think you touched on the SART data at the end, of course, in regards to the outcomes of PGT-M cycles, but how do you go about sort of managing patient expectations and counselling them to be prepared for the outcomes of a PGT-M cycle and the likelihood of success?
Yeah, so I think it's really important to perform that fertility evaluation and provide them with data on how a typical couple would be expected to perform in an IVF cycle at their age and with their fertility parameters. In Australia, we have a website called yourivfsuccess.com.au. It's actually a national database of IVF cycle data that has been submitted, and you can search for where you are in that database. And it's a really useful kickoff point because I think people have the impression that when you're having IVF with the purpose of PGT-M, that you're naturally fertile and therefore you're expected to perform better in an IVF cycle. And whilst that's true with regards to perhaps implantation and removing some factors like endometriosis are probably less common in the PGT-M population, they still are subject to the same rules of IVF. And really the number of oocytes obtained in a cycle and the chance of those oocytes being aneuploid are still the major determinants. So I provide them with the information up front, and I said that you can get very lucky and you can get out in a sprint and get through in your first cycle and first embryo transfer, but more realistically, it's much more of a marathon effort. And our job is to sort of keep them going throughout the process of multiple cycles. And most people, I tell them that they're going to start, I would envisage myself doing 3 cycles at least, in order to have the chance to not only have an embryo suitable for transfer, but to be fortunate enough for that embryo to work.
Fantastic. And in your experience, and I guess this will be quite an Australian-centric experience, but what percentage of cycles do you find will be PGT-M cycles? And do you find that patients are quite, I guess, receptive to moving forward with PGT-M once they've had a positive carrier screening test or some sort of investigation into genetic status?
Well, in Australia, there's a lot of IVF cycles per year, but they're predominantly for infertility. So, 98 to 99%. And I think that the US data would be very similar, that they're looking at maybe 2% of the population undertaking IVF would be for the purpose of PGT-M. But that number is increasing. It's increasing quite a lot. And the acceptability of PGT as a reproductive option, we recently had a national carrier screening study called Mackenzie's Mission, the Australian Reproductive Carrier Screening Project. And they looked at people in that situation, so a reproductive couple who had a high chance result, and about 70% or 80% of them elected to have a PGT cycle as the sort of first option in the non-pregnant situation. So it's very acceptable as an option. It's not necessarily for everyone and for a range of reasons. And it may also be that it may not be suitable once you've had a fertility evaluation. It may not be likely to improve upon your chances of conception if you have a very low AMH, for example. So Fragile X carriers are one of the major groups that are very difficult because you find out your carrier status and require PGT-M, but in fact the condition itself, or the carrier status for the condition, reduces your ovarian reserve. So there are always lots of sort of nuances, but at the end of the day, it's one very popular reproductive option for couples in this situation.
Fantastic, thank you. And I guess Mackenzie's mission is something that's really changing the landscape for patients to access these technologies more openly and with more knowledge, and that's obviously beneficial then for the use of technology as part of their fertility treatment. With programs such as Mackenzie's mission, but also just more discussion and conversation about carrier screening, and I guess the link between our first presentation and your presentation, are you seeing that the types of single gene disorders being tested for is also broadening in your practice?
Yeah, so carrier screening still has a very high hit rate in the very common conditions, and common things occur commonly. But of course, a lot of the value of carrier screening when you do expanded carrier screening is in that long list of genes that people haven't necessarily heard of, but that certainly have a big impact. And then whilst individually rare, they're collectively very common. So I think we are seeing a shift in our practice and seeing more and more indications come through. As I said, we see people who have multiple conditions. I had someone with an X-linked recessive condition at the same time as both of them being carriers of the same recessive condition. It's, it certainly happens more and more. And now that we have that access and availability of that screening, we're seeing a lot of people attend for an understanding of that.
Fantastic. And I guess to look at the other side of the application of PGT-M, what do you find are the limitations? And of course, you mentioned that it may not be possible to develop a test for a specific case, and maybe that's the greatest limitation, but are there any others that you would touch on?
It's very unusual not to be able to design a test. So I always say to people that, with our current techniques, we have a very high expectation of being able to design a test. I think that one of the complications with more and more carrier screening is the availability of references. So typically in the past, couples would have an affected child, and that's how they found out about their carrier status, and that's why they're attending for PGT-M. And in that case, it's very straightforward to design a test. When you have a carrier screening test as a couple, you haven't necessarily declared your intention to have children to your parents. All of a sudden, all of the potential grandparents are having a carrier test for that specific variant, plus a carrier mapping evaluation. It's logistically and sometimes socially complicated, and that is something that we're trying to work out some ways to ease the transition from carrier screening through to PGT-M.
Oh, great. One that's a little bit to the side of PGT-M, but on the topic of PGT-SR, which does fall sort of under that umbrella. But what's your experience with identification of a balanced translocation? And is there a particular technology that you feel addresses this avenue of PGT best?
So PGT-SR, I think, is an underlooked sort of contribution to infertility. I think that we have a very high carrier typing rate in our couples who are infertile. We're very fortunate in Australia that assessment is covered by the Medicare benefits scheme, and as a result, you have patients who they present only with infertility and not with recurrent miscarriage or with some of the more typical sort of manifestations of carrier status, but they do in fact have a reciprocal or a Robertsonian translocation. That's quite common in the IVF population. And these patients, we've transitioned them onto genome-wide haplotyping as well. It's extremely accurate for identification of very small segments of chromosomes, so that we have very high confidence in our results. And it's also given us the ability in some cases, if there's again a family-based reference or there are suitable affected or unbalanced embryos available for analysis, that we can identify which are likely to be carriers or non-carriers of the translocation. They're all suitable for transfer provided that they're balanced, but obviously couples who have just found out this information and the impact on their own fertility have a preference for transfer of the ones that don't carry the translocation. So we've started providing that for couples as well, and found that it's very high uptake.
Fantastic. Thank you very much. So we've managed to answer all of the questions in the Q&A, and I think that was a really fantastic range of questions. So I'd just like to say once again that we've been so fortunate to have a very interesting, informative, and I think also open discussion today about carrier screening and PGT-M and the impact of clinical genomics in IVF. I'd like to thank once again both of our speakers. So Dr. Lee and Dr. Hardy, thank you both very much for giving up your time and your expertise today to be part of the webinar.